Hello. So good morning, good afternoon, wherever you're joining us from. We are so glad you could take the time to really be a part of this important conversation. And we think this is really important. We think that there needs to be more emphasis, there need to be more conversations and more action as it relates to issues of health inequities. And you taking the time to be with us, taking the time to be a part of this conversation, hopefully learning a thing or two, and being willing to take action after this webinar. I think all of those are all meaningful things that we hope that you all would get out from our time today. So much to talk about in an hour, and we're going to jump right into it in a second. A few housekeeping things on the slide there. My name is Osage Abakozian, and I'm honored to be the moderator of the panel today. A little bit about me. I'm the Vice President of Quality Improvement and Population Health here at the T1D Exchange. And we do a lot of really great things at the T1D Exchange. You can check out our website to learn about all of the cool things that we're involved with. But on my note, I'm more involved in two aspects of our programming. One of them is our quality improvement work, the Quality Improvement Collaborative. And my distinguished panelists today are all principal investigators, and we also have a staff that is a member of the Quality Improvement Panel, Quality Improvement Program, and we'll get to introduce the panelists to you in a minute or two. We also have a population health program, and we have been ramping that up and doing a lot of work on population health studies. My colleague would share two different links, a link that explains our Quality Improvement Program and what we do, and another link that summarizes some of the work, for example, we've done in the last year as part of a population health intervention, looking at issues related to type 1 diabetes and COVID-19. So two great resources that will help you see the two broad arms of the QI and population health program. But we have an online registry, and we also have a ton of other programs that might be of interest to you all, our listeners today. But that's professionally about me. On a more personal note, I'm a Black man in the United States. And I've had some of my own lived experiences on what issues of health inequities really mean. And hopefully we will talk about some of those in the questions today. But I'm also married to a Black woman, an African-American woman with type 1 diabetes. So you can only imagine what our dinner conversations are about. We talk about these issues almost every day on some of our own experience as an African-American woman with type 1 diabetes and interactions with the system, the broader system, or even some of the work we're doing and how those key things plays a role. But I'm also very optimistic about the future because I have two energetic, loving kids, African-American kids, that I'm hoping that we can all collectively together build a better society, not just for my kids, but for all the people we all care about, and we bring in our best work to every day. So just to ground us so that we're all using the same language and we're speaking the same thing, when we use the phrase health inequities or we use the term health inequities, we're referring to differences in health status or differences in health outcomes, or the distribution of resources essential or relevant to better health outcomes. So differences in either the status or health outcomes, or these differences based on race, based on ethnicity, based on language, based on where you live, where you work, where you go to school. And when we see these differences, those are all sort of things that helps us really realize how deep these issues are. And it's important that we bring in that lens to the conversation today. It's important that as our panelists share their ideas and their perspective and their thoughts, we think about, we're not just referring to differences in outcomes alone, but also referring to differences in resources and how those resources are distributed. I'm moderating this webinar today from our home office here in Boston. And we're close to a part of Boston called Back Bay. And in Back Bay, the life expectancies of residents in Back Bay, it's 90 years. While in the same city of Boston, just 3 miles away, in a part of town called Roxbury, the life expectancy for residents in Roxbury is 59 years. So you see a more than 30-year gap in life expectancy, same city, But like you might guess, the differences are in who gets to live in Back Bay, who gets to live in Roxbury, what are some of the racial dynamics, what are some of the mix there, what are some of the other socioeconomic factors playing a role. So that's a real world example for us today that we see. But these issues are also so prevalent in type 1 diabetes, and the outcomes for type 1 diabetes, or the resources relevant for helping improve outcomes for everyone with type 1 diabetes. And my panelists would all do a great job really helping us all understand those and what we could do to move this thing forward. So very honored to have my friend, Dr. Sanchez, be with us today. And she's an associate professor for pediatrics and the director of the pediatric diabetes program over at the Miller School of Medicine, University of Miami. She's also the principal investigator with the T1D Exchange Quality Improvement Collaborative for the University of Miami Pediatric Center. Thank you so much for taking the time and being with us, Dr. Sanchez.
It's my pleasure. I'm really looking forward to speaking about this with everyone, as this is an issue that I've been very concerned about.
Thank you. And then another friend of mine, Dr. Carla Sanchez. Dr. Khala, she's an associate clinical professor of pediatrics, University of California, San Diego, also works at Rady Children's Hospital. Dr. Khala brings two different perspectives to these issues. She has worked and lived in Brazil as a pediatric endocrinologist, and also working here at Rady Children's Hospital. She also spent some time as consulting for UN. So she has those two lenses for health equity issues in Brazil, but also health equity issues here in the United States. Dr. Khala, thank you for taking the time.
Thank you so much. And I'm thrilled to be here. And this issue is very dear to my heart. So I appreciate the opportunity and looking forward to share.
Thank you so much. Excited to have you here. And I have a lot of friends today. Another friend, Dr. Majidi. We've been on this conversation and we've worked together on different papers in the last 3 years or so. Dr. Majidi, she's the assistant professor of pediatric endocrinology over at the Barbara Davis Center. She's also the director of behavioral services at Barbara Davis Center. Dr. Shida, thank you for being here. We look forward to the great conversation with you as well.
Thank you so much. I'm honored to be able to speak about this topic that is so very important and near and dear to my heart. Thank you.
We appreciate it. Thanks for taking the time. And then finally, my last friend that's on the panel today, Dr. Orio Dugbeson. She's a staff member at the T1D Exchange, the Quality Improvement and Population Health Manager. Dr. Orio, thank you for taking the time.
Thank you, Sagi. I'm super excited to be here as well.
All right, so we're all excited, we're all ready to go, we're all passionate about this topic, so let's jump right in. So I'll start with you, Dr. Majidi. Can you sort of share with our audience and our listeners today why this topic is of importance to you? What in your personal, professional experience really made this a critical topic for you to explore?
Yeah, so for me, specifically as the daughter of two immigrants who came here from Iran, there was a lot more that happened in terms of seeing health disparities, but disparities in general after 9/11 with the Muslim community, with my parents as Muslims. But even before then, as a child, my parents came here with really, no significant connections or family and worked their way up. So, navigating the cultural differences and the financial differences that I saw, particularly the financial differences through healthcare, as we navigated that, really helped to shape kind of the experiences and the disparities that I saw growing up. And it really made me, in medicine, and then when I became interested in diabetes specifically, to want to work on making sure that everyone, no matter what you look like, believe in, where you come from, are able to get the appropriate and best and equal care that they deserve and that we deserve.
No, thank you. Thank you for sharing that. Dr. Sanchez, same question to you, please.
So when I first started taking care of children with diabetes, we had two clinics. We had a public clinic and a private clinic. And I saw that there was a dramatic difference in how those children were being treated. So when I took over, I combined the clinics so that everybody was together. But it's very dramatic, sometimes just what people have access to and how unfair it can be when you don't have access to a pump or a sensor or even insulin. So, we have the people that are here illegally and indigent, and versus, people with a lot of money and what they can get and the care that their children receive. And your health should not depend on these kinds of things. We should be everybody on an equal footing when it comes to health.
Thank you so much. And Dr. Ori, same question, please.
So for me, I'm a woman of color, and then, we've seen a lot of data that shows that outcomes are worse, lower life expectancy, higher rates of chronic diseases, higher rates of death from chronic diseases, and even lower access to care. And I've been privileged to also work at places with most vulnerable population. I worked at BMC with a group of patients that were Hispanic and Black. They were teenagers, and we're trying to improve outcomes for their children. And I saw firsthand how just helping people out of the hole can help, and we saw that at the end of that intervention, after a year, 100% of the children were able to get immunization, 100% of their mothers were able to get on contraceptives. And, they were able to meet all their appointments and all. I also worked at the Boston Public Healthcare Commission. And a lot of the work we did at the commission was really, for the most vulnerable in our society. So it really informed a lot of the way that I think about, health and health outcomes generally. So I mean this for good.
And then finally, Dr. Khala.
So before coming to the US, as Ozagi mentioned, I did my medical school, pediatric and endocrinology training in Brazil. And I practiced there in our university hospital. And we just see public insured patients at the university hospital. And then I had my private office outside that hospital. And firsthand, I saw the significant disparities between, the two clinics. And it was so severe to the point that I had patients that didn't have a fridge to keep their insulin. And this, together with my passion for diabetes, encouraged me to come abroad and to look for more training. I did research in diabetes. I thought many years ago, that the best thing that could happen is that we could cure diabetes, because that would be the easiest thing to basically, finish or decrease this disparities. And interesting, I came here, and for different reasons, I ended up staying. So I on top of my research, I did my training again, and I started working as a pediatric endocrinology, and I saw that even here in this country, you're facing also disparities and inequities in health. So although I have done all that research, the why I'm doing that never left me, and the experience I have with that very, very poor population really stayed with me, and I think that's what brought me here.
Thank you for sharing that. So Dr. Majidi, we haven't cured type 1 diabetes. It's still with us, and you've spent a lot of time looking at this data for inequities with type 1 diabetes, using some of the data from the Quality Improvement Collaborative. Can you share with our listeners some highlights from that? What were some of the key findings from those studies?
Yeah, so we recently did a study that's currently under review, looking at the last couple of years of data going up to November of 2020, so including pre-COVID and then also some COVID data. And really, in a large population, about 20,000 people who are part of the QI collaborative. And we saw, unfortunately, what we have seen in the past. Things have not, unfortunately, changed yet, with increased health disparities, higher A1C levels in the non-Hispanic Blacks, 2% higher than Caucasians, 1% higher in Hispanics, increased acute complications of DKA and severe hypoglycemia in non-Hispanic Blacks, and then also less technology uptake as well in non-Hispanic Blacks. So, and this was regardless of insurance status as well. So taking that piece out of it, still continuing to see that persistence. And so this large study showed us really that these issues are still persistent, and these barriers and biases still exist, and we still have work to do.
Thank you for sharing that. And Dr. Sanchez, we've also looked in the age of COVID at health inequities among patients with type 1 and COVID. looking at DKA. Can you share with our listeners highlights from that paper and some of the key takeaways from that study?
Yes, so we looked at 180 patients initially from 52 centers. It was from April to August of 2020, so during one of the peaks. And unfortunately, what we found out was that the Blacks had a fourfold increase in having DKA with COVID compared to whites, and Hispanics had a twofold increase. And so those numbers are fairly dramatic. So 55% of those with DKA were Black, 33% were Hispanic, compared to only 13% white. And in addition, the Blacks and Hispanics were more likely to have public insurance, more likely to have a higher A1C, but less likely to have a CMG and pump use. And what's interesting is those who had DKA were more likely to not have a pump or CGM. So Blacks and Hispanics not having pump and CGM, that's going to put them at increased risk for having DKA during COVID. And we know already from other studies that Blacks and Hispanics have increased risk for COVID to begin with, and also increased risk for DKA. So of course that combination can be deadly for some.
No, thank you. That's all true and very revealing study. Dr. Khala, we did also look at patients newly diagnosed with type 1. So both Dr. Sanchez and Dr. Majidi have talked about for patients that are already established patients with type 1, but you've been working with us to look at newly diagnosed patients with type 1, and I know we did publish a study last year. Can you sort of walk our audience through highlights from what we're finding with patients newly diagnosed for type 1 and COVID?
Yeah, so this is, it was a paper that was published in December, and it goes back to the very beginning, the early results that we got with the surveillance registry from T1D and COVID from patients from April to August 2020. And it was a small sample. It was 24 patients that were newly diagnosed with diabetes and were positive for COVID. And we're comparing with a comparison cohort of 124. Most of those patients were 97% were below age 19. And so this comparison cohort was about 124 patients that were new onset, having new onset diabetes, but were negative for COVID. And what's interesting about and shows this in the positive COVID, the COVID positive patients, 71% were in the minorities, while 60% would call COVID negative were white, showing the disparities in COVID in the minority population. And also 75% that have positive COVID were publicly insured, while the majority, almost 60% of COVID negative were whites. At that time, there was no really difference in DKA presentation in these patients, but again, it was a very small group. And then after that, we published, Dr. Sanchez just mentioned the work. But one important thing is that more and more we're seeing data and population studies showing that diabetes incidence is increasing in the world, especially in US, and is increasing specifically in minority populations. So you can go to the CDC, the search study, the search for diabetes in youth for both type 1 and type 2. We're talking about type 1 here specifically, showed that there's an overall increase of 1.9% a year. This is up to 2015. But this is, it goes much steeper when we adjust that by age and by sex, and we look at different races. It's much higher in Blacks. I can give you the percentage. Is while it's 0.7% increase per year in whites, is 2.7% in Black population and 4% in Hispanic. So diabetes type 1 is increasing and is increasing in the minority population. So it's very important, critical that we determine what all these inequities, so we can minimize and mitigate that.
Thank you for walking us through that. And then Dr. Ori, we've been trying to respond to this, and I know that we work together on describing a framework for how we as the broader network can start tackling some of these issues. Can you also walk our listeners through that paper and the framework and some of the things that we're proposing as potential solutions? We're going to have more time to talk about that, but can you just introduce that as well?
So we recently published a paper that talks about, a practical approach to integrate equity into diabetes management. And it's really an expansion of the model for improvement. And it's a 10-step framework. So it detailed how we can use QI tools to tackle equity issues. For most QI projects, you want to first have a SMART aim. So in this paper, it talked about instead of having just a SMART aim, which is smart, measurable, specific, and all that, we want you to start thinking about, the ER, which is the equity revision. So instead of having a goal to increase CGM adoption by 40% in your clinic, why not think about increasing CGM use by 20% in high-risk patients? So we really want you to start thinking about all that. He also talked about how, instead of looking at your baseline data, you want to drill down this baseline data to look at races, what's the number for whites, for blacks, and all that. It's a really comprehensive paper, and I think the link is on there, so you can look through that paper.
Thank you all so much. So so I think one recurring theme I'm hearing is the issues of health inequities. There are many things contributing to that, but I think one phrase that we get to hear a lot about is systemic racism and how that contributes to this issue. So I'll start with you, Dr. Majidi. Can you speak to systemic racism, what you mean by that, and how that affects minority patients as well, patients of color?
So I think for me, when I think of systemic racism, it really starts with what the previous American history and laws and acts that have been put in place that continue to push the disparity and the differences that we see, whether it's from what you were mentioning at the beginning in terms of where people are able to live, the loans that they're able to get. I think that, this is something that we may not think then becomes integrated into medical care, but it very much does, because that leads to the inequities we see and the ability to get the resources to get the technology that they need. And so really, I think that's where things come into play in terms of how that affects medical care and the disparities that we see in terms of what some patients are able to get or are given versus others.
Any other panelists wants to take on that question as well? Yeah, go for it, Dr. Sanchez.
I can go next.
Okay.
Usually issues of racism and all that are always very difficult. No one really wants to talk about it. But for me, I think it's basically a form of oppression, it's to the advantage of a more dominant group. So it's a kind of prejudice where a particular race feels like they're better because of their skin color. Really, it's a form of superiority complex, by a more dominant race. So that's my definition of racism. And we know that it affects everything, like Osage talked about, to where you live, to this criminal and social justice system. Yeah, so.
And Dr. Sanchez, you have some thoughts on that?
I think also when we talk about like health racism is what are expectations that are given to patients, like, well, you're Black or Hispanic, so we expect you to have a higher A1C. We expect you to have worse control. And so maybe we're not pushing and to have the best control that we can have, because just automatically people have assumptions about healthcare for patients and what they're capable of, both physically and mentally, and what they can do, and not always looking to have the same level of care and outcome that you might expect from another race.
Thank you for bringing that up, because that ties very neatly into my next question on the expectation or some of the bias there. We know that issues of race and racism are on multiple levels, and Dr. Sanchez, you talked about that kind of provider bias and how that plays a role. So, Dr. Khala or Dr. Shida, can you sort of speak to provider bias and, sort of on that level? Again, there are multiple levels, and it's not the only, provider bias is not the only thing driving these inequities. But for on provider bias, how does that really play a role in some of the outcomes we see?
I think, putting both questions together, I see the inequities on resources and in policies. Our day by day, for example, is ordering devices, right? Ordering technology. And to order technology for a public insured patient, as you all know, all the doctors that are in this webinar know the amount of paperwork you have to go through. It's so much easier. For a private insured family, you order, is there. Mostly they leave the hospital already with their CGM or whatever it is. Everything is easy. For a public insured, you have to go to a pile of paperwork and appeals and letters and calling. And sometimes the family has, language barriers. It's difficult for them to find who they have to call and go after. What's missing is missing a piece of paper, is missing this. So it's not the same, right? So it's for this particular population, it should be easier, if anything. It should make it, things should make in a way that guarantees them the same right that everybody else has. And sometimes providers, they'll just look, oh my goodness, I have to order this, I have to go to this pile of paperwork. You know what, let's see what he does the next visit. And maybe it will delay. I'm not saying that people are going to do that, but that's what happens. That could cause that, right? So that's my little bit there.
No, thank you for sharing that. Dr. Shida?
Yeah, so I think provider biases, there's a couple of different ways that I think about it. I think one is the implicit biases that we all have. And I think that, that comes from society and what we see around us, what we see in the media. And I think that plays a role in everybody, whether you're a provider or not. But I think that it's important to recognize that those biases exist. And I think that we're unfortunately slowly, but are starting to realize more and more that. So I think one of the hopes that I have from this webinar is also that we start not only to look at all of the issues around us, but the issues within ourselves that we have. And it doesn't mean that it's purposeful or that we are consciously having it, but it exists. And I think the way to improve that for providers and for everybody is to first recognize it and then work on improving it. I think the second piece is also going back to the differences that have come over years and years that make it harder for people of color to become providers in the first place. It's hard for patients if they're not seeing somebody from their culture. It's different, and it's not to say that somebody who is not of the same culture or background won't be able to provide you excellent care. There's just a difference when you're able to see reflected in a provider, somebody who understands those experiences and that background that you are having, and can see that more easily.
So can I build on that comment, Dr. Shida, talking about now we're going to transition into what do we do about all these issues? And I want to build on what you just talked about on providers that look like you, sound like you. I know that your center has been involved in some fabulous programs that are trying to address some of these issues with a different lens. Can you share some of those bright spots? What's working? What are those results looking like? And give us some hope on how we can address some of these issues.
Yeah. So one of the great programs that we have that is being led by Dr. Gerard Gonzalez is the Latino program. And when Dr. Gonzalez came to the Barbara Davis Center about, I want to say 6 years ago, maybe now, maybe more than that, one of her main purposes was to try to improve healthcare in the Hispanic population in terms of diabetes care. And she created a group visit, a shared medical appointment model called the Latino program, in which people who are Spanish speaking or not Spanish speaking, but are of a Hispanic Latinx background, are seen in a group visit where the people who are involved in that clinic have a background that is either similar to them or able to speak Spanish, and through that provide additional education that's more specific to their culture, what they eat, what people, who are Hispanic are more likely to eat in terms of their, their foods that they enjoy. And, in terms of making sure that other family members are involved in the care, because we know that in some communities, the Hispanic community, the Middle East community, the family is a large unit. It's not just parents and children, it's grandparents, it's aunts, and they play a big role. And with the work that Dr. Gerard Gonzalez did, she was able to double the uptake of technology in kids and in adolescents, both in particularly in pump, but also increase in CGM, and decrease A1C levels as well. So this is something that now she's expanding to other states as well. So not only was it a success for our institution, but she's now working hard to expand it to other centers as well.
Thank you for sharing that bright spots for us. Dr. Sanchez, Dr. Khala, any bright spot examples that you've been involved with and trying to really tackle this issue head on? Dr. Sanchez, we could go first for you.
So, I mean, when we switched over to being able to offer everything in Spanish to people who wanted it, I think made a huge difference, from sensor training to pump training to carb counting classes to basically anything we would want to do in Spanish, we can offer to everybody in Spanish. And just really saw a big uptake in advancement of technology, very high sensor use. And then as more people, the word got out, more people using it, then it kind of spread through the community where people were more accepting of it, because that makes a difference too. If your community doesn't accept wearing pumps, it doesn't matter who's telling you, if your physician's telling you. So getting it out to the community and then having people coming to us saying specifically, I want this technology for my child. And then also trying to work in Miami with our large Haitian population and trying to understand the Haitian culture more in terms of understanding what are barriers there to progressing with care as well. I think that's made a difference in being able to offer more things in languages and cultures that are shared with the patients. And of course, when we shifted the clinic to putting all the patients together, everybody mixed together, and then just basically with the goal of everybody gets the same standard of care. So no matter who you are, no matter what your insurance is, what your background, we're going to try to push your standard of care to the highest level possible.
Thank you. Dr. Khala, examples of bright spots?
So UCSD and Rady Children's Hospital, I think they're very wonderful institutions in trying to minimize disparities. And at UCSD, we have the Hispanic Center of Excellence, which supports Hispanic medical students, and with the idea to increase the number of Hispanic medical providers in the community. The same thing, going back to what Dr. Sanchez and Majidi have discussed. There's also most recently the Denny Stanford Institute for Empathy and Compassion, which is a wonderful the place that is supporting multiple studies, training, and funding work on compassion related to anti-racist compassion and relationship between patients and their providers. And at Rady's, we have been working with a pilot of CCS, it's called CKC, California Kids Care, which is allowing us, one of our QI projects is to use nurse navigators to reach out to families from public insured families to provide, basically hold their hands in between visits, helping them, schedule for next visit, and talking to their school, nurses school, and help them with paperwork with devices. And soon we'll have that data to show, but so far it looks very promising.
Thank you for sharing that. And Dr. Ori, I know you hear all of these stories too, and in coaching and working with the teams. Are there other examples you want to highlight on bright spots on what other sites are trying out in this area?
Yeah, so a lot of sites are trying out a lot of amazing ideas like Dr. Khala said. Ready is one of those sites that are working with their high-risk patients. We also have SUNY working specifically with high-risk patients and holding their hands. An interesting one is also from Alabama children. They're working to increase CGM use, especially for their high-risk patients. And they've been able to close the gap by about 15%. They've closed the gap of prescription disparity. Prior to the project, they had about 10%, 27% gap in prescription, but now it's about 10%. So they were able to increase the number of Black and Hispanic patients that got on CGM. So a couple of other sites are doing projects. Even Dr. Sanchez's team as well, they are also working with their high-risk patients to make sure that they are downloading data before clinic, and it's specifically those very difficult patients to reach. So it's basically just holding them and making sure that they get it done. So a lot of amazing QI projects.
No, thank you for sharing those examples. So I'm hearing 4 broad things, kind of approaches to this issue. On the personal level, working directly with vulnerable patients or with patients that the system might not be favored, it might not be structured to favor them. Working on the provider aspects with provider training, provider bias intervention, those sort of things. Working on the institutional level, so you're getting some of the programming around institutional Hispanic classes and what have you. And then even working more on the systemic and broader approach to like we've discussed. So to sort of take it on to the next level, how do we bring in voices of patients impacted to be in this conversation? Now, we did structure this panel to be a provider-facing panel and sharing the perspective of providers, and that was intentional. But how do we bring in patients, people of color, people impacted to be able to work collaboratively with us to address this issue? And I can start with you, Dr. Shida. Any thoughts there or perspective?
I mean, I think it's as simple as just being conscious of the fact that whatever change we want to make in clinic, we can't make unless we're hearing the voices of the people who are struggling because of these barriers. Because we as, medical professionals only see one side of the story, and we can, think and make theories as much as we want, but until we, are hearing the voices of the people, of the patients and the families themselves, we won't know the best ways, or to know if what we're planning on doing is going to be successful, or if there's something that we're missing, if there's a blind spot that we're not realizing, that's really important. So I think, one of the things about the Quality Improvement Collaborative is that we encourage patient representatives to be a part of every single site so that we can hear those voices in everything that we're doing, and help us to be able to move forward with the projects that we do. So I think there's definitely an importance to making sure that they're a part of every aspect of this that we're trying to improve upon.
How about you, Dr. Khala? How do we bring in patient voices to be a part of this work?
I agree. I think the first thing is listen to them, right? Whatever you're going to do, you need to listen. So just one example, we noticed in the very beginning of pandemic with when we have to switch to telemedicine very, very quickly, we're so excited, and we saw those people joining and downloading their devices and everything. But and they were really happy about it. We did a surveillance and a survey, and everybody, oh, this is great, this works great. But then you look who is really showing up for these visits in the beginning, and was mostly the private insured patients. And there was, at least here in the beginning, there was a significant decrease or increase on no-show and cancellations rate for the public insured patients. And so we have now to send a survey to see why is that happening, right? So if you don't look at those things and you don't ask, so they might not have a decent internet connection. They might not have a device. They don't have, they're missing a cord, or they don't know how to download some app. And so this is one of the QI projects that we're working on. And thanks to T1D, thanks to you guys, to allow us to put together this QI team, and to, of course, not forgetting the Hemsley Trust Foundation. We're able to put some resources and someone that would help those patients, to provide cords, to provide whatever they are missing to allow them to join the telemedicine like everybody else.
Same question, Dr. Sanchez. How have you been bringing your patients of color to be a part of the solution?
So one of the things that I've noticed is that patients won't necessarily talk to me or their parents as the physician, but they will talk to our nurses, they may talk to our MAs, they'll talk to our psychologists. And so I found that it's really helpful to listen to what they're telling to the entire team, because in the physician visit, a lot of times they just, it's just concentrated on specific diabetes related issues. And they won't tell me about the food issues or other things that are going on in their lives that may impact their care. But they may tell the psychologist, they may tell the MA at check-in. So I found using our entire team and some of these other people may be people of color or somebody else that they feel they can more bond with a little bit more closely. And so I find that that's a great source to use to get this information and then to be able to help the patients with that.
Same question, Ori. Any thoughts on this?
I feel like, the 10-step framework really talks about how we should, involve patients of color in our QI teams. A lot of teams right now, about, I'll say 50% of the sites have patient or parent representatives, but 50% don't have that right now. So I feel like there's still a lot of room for improvement. So for the sites that already have, they can use the same approach to, to involve another person of color. For sites that, don't have yet, they can think about ways, like Dr. Sanchez that said, like Dr. Shida and Dr. Khala said, all those things together, so that it can add patients of color to their team.
Thank you. So listening today, some of our other colleagues outside of the medical space, from device companies, from pharmaceutical companies, and representative from other sectors. So what role did they have to play, sort of the broader outside the clinic, stakeholders? What role should they be playing in looking at this issue? So Dr. Shida, any ideas on, what should device companies or insulin manufacturing companies be doing to support this topic?
I think they need to play, and they can play a huge role in this. And I think that it's to help work. One of the aspects is to help work with us, as we're saying, and we're explaining all the difficulties with technology uptake that we're seeing, to figure out what are the ways that we can help reach this population, and what are different ways to help reach this population. Because I feel like, a lot of industries, and I'm not saying that these industries do or don't do this, but a lot of industries in general are very much geared towards, their marketing is geared towards the Caucasian population. And so it's a matter of, figuring out how we can, overcome those barriers and say, what we're marketing towards right now is not the entire population. And how do we start working on that together to be able to get everybody the care that they need and the technology that they need?
Same question, Dr. Khala.
I think just starting with, for example, promotional material, right? So it would be a huge help if the promotional material was geared for different cultures, because we know that you're saying Hispanics is the family is a unit, is not just the patient. So you have to have different promotional material according to reach out to different, cultures. And so, of course, in translated in Spanish, and really more appealing according to everyone's culture. I think that would be an incredible help.
And Dr. Sanchez?
I think not just have it in Spanish, but have pictures of people of color on the brochures. It seems like when you see an ad and there's pictures of color, it's always geared to adult type 2 diabetes is people of color, and type 1 is always Caucasian. And we know that, of course, this is across the spectrum where people are, so it'd be so helpful to have pictures of, Blacks wearing a pump. And this is something that I can then give to my patients, as well as having it in different languages. And the other thing, of course, would be great is to have support programs. You know, some of the insulin companies do this, but everybody to have funding programs that indigent patients or low-paying patients can apply to get their supplies, be it an in-pen, a pump, or a different insulin.
Same question to you, Dr. Ori. Any thoughts on that?
Yeah, I think I would say it's really important for external stakeholders to work with us to really understand the data, you know, first, so they see that, you know, the disparities exist, and then, you know, we can work together to think about ways to increase access, you know, through funding. And I also echo everything else that everyone has said, but I think it's really important for them to, you know, to help with access and looking at the data.
And if I can put you on the spot a little bit, Ori, I know we're in conversation with a specific device company now to really start to look at this issue with pumps and CGM. Can you just briefly sort of talk about what that project would look like and what we're trying to answer with that project? So
I really love that project. That project is like a pet project to me. We're trying to increase the use of CGM pump and CGM and insulin pumps amongst Blacks and Hispanics. It's already getting a lot of enthusiasm from sites, because I've mentioned it to a couple of sites and a lot of people are really excited about it. It's going to have two phases. So the first phase of the project would really be with the providers. We'll train them on racism and implicit bias, because we're hearing, you know, I was talking with a site one time, and, you know, one of the providers made a comment. The comment is from a really good place. You know, she said, oh, she doesn't prescribe CGM to all her patients. There is no way she'll prescribe CGM to all the patients, because there are certain patients that, you know, if they don't pick their calls, I don't prescribe CGM. If they don't engage on the QI on the portal, she doesn't prescribe CGM. That's coming from a good place, but that's some bias there, because the truth is those patients that are not picking up their phone calls, those patients that are not engaged are most likely the patients that are struggling. Those are the patients that we really need to get out of the hole first, you know, before we start, you know, even talking about CGM. So the first phase will take care of that, you know, and then the second phase would be when we'll start testing out interventions, specific interventions to increase CGM and insulin pumps use with the population. So more to come about that project. We have a protocol already, and we're piloting this with just about, you know, 4 to 6 sites. So we don't want to talk about it too much, because we don't want to have too many people, you know, than we can take.
No, thank you for sharing some of the highlights from that, and of course we will continue to share results and learnings from that. So, you know, we're wrapping up now. We're right at we have about 10 minutes more. I still have a lot of questions, but we'll sort of get to where we can. And hopefully we can continue. This won't be the last of this conversation. There'll be many more opportunities to discuss this issue, share bright spots as well. So let's sort of talk about policymakers. Let's talk about, you know, and by policymakers, I mean both sort of institutional policymakers, so in the local institutions, but also kind of state policymakers and even federal policy. So I'll start with you, Dr. Shida. What's the role for decision makers, policymakers from the different levels to be active partners in addressing equity issues in type 1?
I mean, I think that plays, that's a huge role, because it speaks to not just looking at the issues within, you know, every institution, but looking at things on a larger scale in terms of what are changes that we can make within a hospital, within a clinic, but also statewide to help with the disparities that indirectly and directly impact somebody's medical care. And I think that, you know, now is the time where people are starting to be more receptive to this. And I think that unfortunately, when people become more receptive to it, it's because something has happened that has forced them to be receptive. And it's not always long lasting, even though we want it to be. And so I think it's taking the opportunity that we have now and continuing to push so that those changes can occur and can be long lasting. So in a sense, striking while the iron is hot and saying, like, you know, this is something that we're seeing, this is something that we're all seeing right now. So how can we make these changes that can be impactful and long lasting?
Thank you for that. And Dr. Khala, can you respond to that same question on policymakers and their role in this work?
So I think somehow the pandemic placed like a magnifying glass on the disparities. It was something, it was very acute, it was very rapid, and I think things became much more clear. And I think we need to take that chance right now as a group like T1D Exchange. We have the data, we have the numbers, and we need to show where we go from here, right? We're showing there are problems, and we might have some solutions for that. So I think we can have the power to make changes at much higher level. And this needs to be done as soon as possible.
So thank you. I'm just using the other part of my eyes to look at some of the chats, and there are a few questions there. And I'll ask one question from one of our listeners. So how are you collaborating with communities to help children? I believe that's probably for minority population and T1D that might have barriers such as language barriers to navigate different resources in the community. So I'll paraphrase that question the way I understand it. How are we, any of the panelists, how are you working with those communities to really help bring that information, bring that resources to the community level and partner with the community on that? Dr. Sanchez, can you share some thoughts on how you're doing this now at University of Miami?
So, we tried to ask the patients what they needed and how to provide the care for them, and then try to involve things like other organizations that we have in the community, like the JDRF, and we have the DRI here, to get the word out to what's available and to have more teaching and education sessions that everybody's kind of available to come to, and then spread the word that these are available to everybody in multiple languages to help out with that.
We're seeing more questions coming. I'm more than happy to abandon my own question. We'll just take the questions coming in from here. So in your opinion, and Dr. Khala, you can take this, in your opinion, do you think diabetes technology itself is inclusive, or is it also an opportunity for improvement? That's
an absolutely fantastic question. And there is a fantastic paper that I think is in your list, a decade of disparity in diabetes technology use and A1C. And it was just published like 2021. That show both in US and in Germany that although there's an increase in using technology, insulin pumps, CGMs, A1C is actually going up overall, especially in the US. And when you break down by different socioeconomic status, the lowest socioeconomic status is where they had less technology device, less access to technology device, and the higher A1C. So technology is wonderful, but if you don't take care, if you don't respond to the equity issues, you're gonna widen the gap of disparities. The same thing I saw in the beginning with telemedicine visits, it's fantastic, but it might be fantastic for some and not for all. And they might just left behind, right? So we need to be very careful, and I think the work that we have to do to improve the access to technology to minorities is crucial, right? We know that in the future it will be a much higher percent of minority, and if they don't have an insulin pump, they don't have a CGM, they're going to be behind. They're just going to be left behind. And so I think, thank you so much for that question.
No, thank you for sharing that. And then another question, and we'll take this other question. So, and Dr. Shida, if you can take this question. So what recommendation or additional recommendations, I know we talked about a few of them, are there additional recommendations you have for the diabetes technology industry to be more inclusive in the development? And I like the piece about the development and uptake of technology. So any additional recommendation to be more inclusive in development and uptake of technology?
I think that I think a couple of things. So I think one, in terms of the development, a lot of studies that are done during the development process and the trial phases of assessing for, safety, efficacy, does it work? There are very specific requirements, and I can understand some of them, but they tend to eliminate a lot of people who are not who don't have private insurance, who don't have the best A1C. So they gear it more towards people who have a lower A1C. So we're seeing the results in a very sterile environment, a very specific population, and not including people who come with barriers, who come with higher A1C levels, and how technology impacts them, and what we can do to improve for those patients. And then what we end up seeing is when it then goes to market, the people who have higher A1Cs who weren't within those studies have all of these issues that we didn't address and we didn't think of and we didn't solve. So I think that's one big piece that can be helpful. The other thing, just to follow up on the last question, that's similar, and again, I think that is an excellent question, is that there is this idea that has been around for a while that pumps should only be for people when they reach a certain A1C level, that if you have an A1C level above a certain range, that a pump will not work for you. And I think that that is something that we need to stop thinking about, because I think there's a lot of different reasons that go into why somebody has a high A1C, and it doesn't mean that they're not capable of diabetes management. So I think that we need to, work on eliminating the thought process that only certain people with a certain A1C are able to be successful with a pump.
So Dr. Ori, thank you so much, Dr. Shida. Dr. Ori, you're getting a lot of love from the chat. So one of the listeners is asking, how do you advocate for yourself if you're a patient that might have experienced some of this bias in not being prescribed technology? How do you advocate for yourself, or any thoughts you might have on being a spokesperson for yourself to advocate to get those devices?
Honestly, I would say that, as a patient, you first want to make sure that you have as many information as possible. So you want to make sure that you're learning, you're reading about, the devices, what they're used for, and then you ask your provider for it. Don't be afraid to ask your provider, and then if your provider feels like, it's not something that, would work for you, they will tell you that, oh, you can't use this, or, oh, yes, I'll totally prescribe it for you. But I think it's important to, to be able to speak for yourself and ask.
Oh, wow. Really robust discussions. So many more things to cover. We knew we're not going to be able to do this in an hour, but we took a shot at it. And I think we did discuss a lot. But of course, these issues are deep and a lot of other things to cover. So again, thank you so much to our panelists. Thank you to everyone listening, sharing your questions, sharing your thoughts. We've had a great time really discussing some of these issues. We will share the link to this recording, and we're going to share all the resources that we've highlighted today with everyone that registered for this webinar. It's been a pleasure, and I'm optimistic. I'm hopeful. I know that a lot of people want to deal with this issue and tackle it head on, not just our panelists, but to everyone listening. So we hope you can reach out, be a part of the journey, be a part of the conversation, and to really get a space where we can truly achieve equity, where everybody has an opportunity to improve outcomes. So till we connect again, thank you so much. Enjoy the rest of your day, everyone. Bye for now.